facing the challenge, inducing posterior vitreous detachment in difficult situations. The vitreous cutter on active suction is able to achieve posterior vitreous detachment in most patients, but there are times you could do with some additional assistance. Here, the use of triamcinolone helps in demonstrating the hyaloid separation. In young patients, the posterior hyaloid is very adherent and the cutter is unable to get a purchase on the hyaloid and break the forces of adhesion between the hyaloid and the retina. In this situation, creating microperforations with a pick allows fluid to enter the potential space, and a soft tip cannula with suction acting on its tip is now able to lift it off the retinal surface. Note the subtle fluid wave as the clear hyaloid separates from the retina. Let's see this experiment. Here is a polythene sheet plastered on a moist surface, and the vacuum cleaner is unable to get a hold of the sheet or lift it off. However, if microperforations are made on the sheet with a fine needle, the vacuum cleaner is able to engage and lift the polythene off the surface. In the presence of a vitreoscheisis, vitreous cortex is seen separating in multiple layers without a definite or clear posterior vitreous separation. Here, a repeated use of a cutter or forceps fails to induce a posterior vitreous detachment. In this situation, a pick or spatula can create an opening in the posterior hyaloid, which now provides an edge to lift the hyaloid face using the cutter. The vitreous, which is generally very adherent, needs to be carefully cleared. In high myopia, PVD induction remains a challenge. The presence of a ring-like structure resembling the Wyeth's ring can be misleading, and on staining with triamcinolone, the entire cortical vitreous is seen adherent to the retina. The vitreous here may come out in bits and needs meticulous and complete removal with a forceps. To avoid an iatrogenic damage to the fovea in vitreomacular traction, PVD induction can be initiated with a pick or spatula starting from the fovea and proceeding outwards to complete PVD. Thus, a PVD induction in a vitreomacular traction can be safe and atraumatic to the fovea. In patients with proliferative diabetic retinopathy, it appears tempting to lift the hyaloid face with a forceps along with the vascular proliferations. However, strong adhesions can create a retinal break as seen in this video. A better technique is to divide and isolate the vascular proliferations before they can be safely separated from the retina. Though the cutter alone is sufficient to induce PVD in most situations, some helpful additional methods are use of triamcinolone, use of a pick or spatula to break adhesions, active suction on soft-tipped cannula, and use of forceps in high myopia. Thank you.